Welcome to the Federated States of Micronesia Prescribing Opioids for Chronic Pain Training. My name is Tupua and I will be your trainer for today. Before we get started, I'd like for each of you to briefly introduce yourself, giving your name, title, and organization. The following video is designed to give you the tools you need to properly prescribe opioids for chronic pain. This training is informed by and follows the CDC's guideline for prescribing opioids for chronic pain. The CDC guideline is voluntary. It is intended to represent best practices and summarize evidence found in 2016 when a panel of experts convened to look at how pain management in primary care is approached. We will refer to going forward as the guideline. Please keep in mind, this training will not cover the use of opioids for acute pain, active cancer treatment, palliative care, or end-of-life care. This training, however, does address specific learning objectives. After completing this training, you should be able to explain the purpose of the guideline, understand and describe the 3 key pillars of the guideline, understand key guideline recommendations, and recognize the benefits of utilizing those recommendations. We also want you to walk away feeling more knowledgeable about specific practice objectives. After completion, you should be able to explain at least one evidence-based non-opioid therapy for chronic pain, understand how to calculate dosing and morphine milligram equivalent, or MME, for various opioid agents, recognize key factors for opioid misuse, and identify signs and symptoms of opioid addiction and misuse. Now let's focus on the learning objectives as we complete the pre-assessment form, which gauges your current understanding of the guideline. We begin with a review of the opioid epidemic in the United States and strategies for preventing the epidemic from impacting the Federated States of Micronesia. As prescribers, your role is important in addressing and preventing the opioid epidemic. There have been nearly 450,000 deaths from opioid overdose in the U.S. between 1999 and 2018. We know that in the U.S., as many as 1 in 4 people receiving opioids long-term in a primary care setting struggle with opioid addiction. In fact, almost 36% of all opioid overdose deaths involve a prescription opioid. We will now pause the video to discuss the statistics. As you can see, the CDC guideline has 3 key pillars. Number 1, determining when to initiate or continue opioids for chronic pain. Number 2, opioid selection, dosage, duration, follow-up, and discontinuation. And number 3, assessing risk and addressing harms of opioid use. For the first pillar, determining when to initiate or continue opioids for chronic pain, the CDC has developed 3 key recommendations. First, avoid prescribing opioids as the first line of therapy. Second, establish goals for pain and function. And finally, discuss risks and benefits with patients. When considering prescribing opioids for chronic pain, remember, while opioids can reduce pain in the short term, there is insufficient evidence that pain relief is sustained over time. Furthermore, it is uncertain whether opioids improve function and quality of life, and there are serious risks associated with opioids. There are 3 main types of opioids: natural, semi-synthetic, and fully synthetic. And each opioid has different generic and trade names. In your materials, you will find a table in Appendix A labeled Types of Opioids, handout number 1. That lists the types of opioids along with their associated generic and trade names. When prescribing opioids, start with the lowest effective dosage of immediate release opioids, such as immediate release oxycodone, oxymorphone, hydrocodone, and morphine. The guideline defines chronic pain as lasting more than 3 months with the possible presence of tissue degeneration. Remember that opioids are not the first line of therapy given the associated risks, including but not limited to overdose and opioid use disorder. Providers are encouraged to first consider non-opioid and non-pharmacologic therapies for pain relief. Common non-opioid medications and pain relief therapies include acetaminophen, an analgesic drug useful for arthritis and lower back pain. NSAIDs, which are nonsteroidal anti-inflammatory drugs useful for arthritis and lower back pain. Gabapentin, an anticonvulsant that improves certain neuropathic pain conditions. Pregabalin, an anticonvulsant that improves certain neuropathic pain conditions and used for fibromyalgia management. And tricyclic antidepressants and serotonin, norepinephrine reuptake inhibitors. These antidepressants are an effective analgesia for neuropathic pain conditions and fibromyalgia symptoms. When developing a treatment plan, providers should consider a combination of therapies. Physical therapy can help patients with learning stretching and strengthening exercises. Interventional treatments such as joint aspiration and injections can also provide pain relief. And cognitive behavioral therapy and other types of behavioral treatments can help patients learn ways to manage their chronic pain. It is important to note that before initiating cognitive behavioral therapy, practitioners are required to contact the patient's primary care provider or PCP. This is necessary to, number 1, inform the PCP that the patient has agreed to participate in cognitive behavioral therapy for chronic pain, and number 2, to facilitate communication between the PCP, practitioners, and the patient about the patient's physical capabilities. When considering an opioid therapy, providers should discuss all risks and benefits with the patient. Remember, if a provider decides to prescribe an opioid, the prescription should be combined with non-opioid and non-pharmacologic therapies as appropriate. Opioids have been shown to be more effective when integrated with these alternative therapies. Providers should also work with the patient to establish pain goals using a validated pain scale instrument to determine level of pain. CDC recommends using the Pain, Enjoyment of Life, and General Activities Scale, otherwise known as the PEG scale. Refer to Appendix G Validated Screening Tools, PEG handout number 7. Providers should understand the common side effects of opioids and inform patients that even when prescribed and taken properly, side effects are common. These side effects may include tolerance, physical dependence, increased sensitivity to pain, constipation, nausea, vomiting, and dry mouth, sleepiness and dizziness, confusion, depression, itching and sweating, and low levels of testosterone that can result in lower sex drive, energy, and strength. Patients should also be made aware of potential withdrawal symptoms. Appendix B specifies the approximate time from initiation of opioids to the onset of withdrawal symptoms such as drug cravings, anxiety, insomnia, abdominal pain, vomiting, diarrhea, and tremors. Now it's time for our first group activity and knowledge check. For the next 8 to 10 minutes, we'll break into small groups for a brief discussion. Then we'll go through a typical scenario you may face and answer questions. Now we'll move into the second pillar in the guideline, which addresses opioid selection dosage, duration, follow-up, and discontinuation. For this pillar, Pillar 2, CDC developed 4 key recommendations. This pillar stresses that providers should prescribe immediate release opioids and the lowest effective dosage when initiating and prescribing opioid therapy. When prescribing opioids for acute pain, providers should prescribe the lowest effective dose in short durations. Typically, 3 days or less is enough. Providers should evaluate the benefits and harms within 1 to 4 weeks of opioid therapy initiation and then follow up every 3 months or more frequently. The guideline says to prescribe patients immediate release (IR) opioids instead of extended release long-acting ERLA opioids, since ERLA opioids have the greater risk of non-fatal overdose, particularly within the first 2 weeks after the initiation of treatment. There is insufficient evidence to compare the effectiveness of extended release long-acting opioids versus immediate release opioids. However, there is a higher overdose risk with ERLA opioids when compared to IR opioids. When initiating opioid therapy, there is not a minimum dosage level. CDC explains that increasing dosages to 50 or more morphine milligram equivalents, MME, a day increases the risk of overdose without increasing the benefit of pain management. Providers should avoid increasing dosage for chronic pain management while keeping CDC's response to misapplication of the guideline in mind. Assessing and reassessing dosage to ensure appropriate pain management is necessary. Avoid titrating or increasing opioid dosage to greater than or equal to 90 milligrams a day, or carefully justify this decision. As always, reassess risks and benefits for patients at any dosage. Long-term opioid use often starts with treatment of acute pain. So when opioids are used for acute pain, it's best practice to start with a short-term script by prescribing the lowest effective dose opioids for less than 7 days. 3 days or less will most likely be sufficient. More than 7 days will rarely be needed. Do not prescribe opioids just in case or for a potential pain increase. Convey to the patient that any change, especially an increase in pain, requires an assessment. CDC also recommends monitoring and evaluating benefits and harms within 1 to 4 weeks of initiating opioid therapy. After the initial evaluation, continue evaluating at least every 3 months. You can also optimize other therapies whenever feasible. Follow up with patients on treatment goals to determine if opioids can be reduced or discontinued, and work with patients to taper opioids. Be sure to acknowledge how difficult tapering can be when a patient is fearful of pain or withdrawal. Tapering or discontinuing of immediate release opioids should be considered when your patient has no sustained clinically meaningful improvement in pain and function, is taking opioid dosages equal to or greater than 50 milligrams a day without evidence of benefit, is on concurrent benzodiazepines that cannot be tapered, requests dosage reduction or discontinuation, experiences overdose, other serious adverse events, and or warning signs of such events. And now it's time for our second group activity. In the next 8 to 10 minutes, we'll break into small groups for a brief discussion, and then we'll run through a scenario and answer a related question. Let's move into the third and final pillar we will cover in this training, which is about assessing risk and addressing harms of opioid use. There are 5 key recommendations focused on strategies to mitigate risk. Evaluate risk factors, review prescription drug monitoring program data, PDMP. In the event there is no PDMP in place, as is the case in the Federated States of Micronesia, contact your state's pharmacist for information. Use urine drug testing, avoid prescribing opioids and benzodiazepines concurrently, arrange treatment for opioid use disorder. You will find in Appendix D entitled Opioid Risks Handout Number 4 that CDC outlines the harms typically associated with opioids and provides a list of common side effects, serious risks, and populations at risk. Please take a moment to review the table to gain a better understanding of opioid-related harms. CDC reports that illicit drugs and alcohol are contributory factors on a substantial proportion of death certificates for opioid-related overdose deaths. So it is important to incorporate risk-reducing strategies into a patient's pain management plan. According to CDC, this single substance use screening question has been shown to be very effective in getting information from patients. This screening instrument asks the patient, how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? In the event a patient responds positively to the single screening question, providers may utilize the Addiction Research Foundation's ARF Drug Abuse Screening Test, DAST-10, for conducting a full drug screen. According to ARF, drug abuse refers to, number 1, the use of prescribed or over-the-counter drugs in excess of the directions, and number 2, any non-medical use of drugs. Another validated screening tool is the Alcohol Use Disorders Identification Test, also known as the audit. This tool focuses on screening for unhealthy alcohol use. We will now pause for 3 minutes to review Appendix F entitled Adverse Childhood Experiences Handout Number 6, also known as ACEs. We'll also look at Appendices G through J for details on validated screening tools, PEG, ACEs, DAST-10, and audit. These are supplemental materials that will support your conversations with patients. A prescription drug monitoring plan, or PDMP, is an effective way to track opioid use when starting therapy and throughout the prescription period. This could vary from reviewing the PDMP after each prescription or every 3 months. Given that a PDMP hasn't been established yet in FSM, work with the patient's pharmacist to determine if the patient is receiving opioid dosages or dangerous combinations that put them at high risk for overdose. Now we'll pause to go over our PDMP handout found in Appendix E. In some instances, based on a patient's history of overdose substance use disorder, higher opioid dosages, and concurrent benzodiazepine use, consider prescribing naloxone. Naloxone can't reverse severe respiratory depression. Before starting opioid therapy, use urine drug testing and consider testing at least annually to assess for prescribed medications and other prescriptions or illicit drugs. Note, this is a very helpful strategy for providers because some patients may be unaware that they are taking opioids. What is recommended if a urine test is positive or expected to be positive? Well, before testing, ask patients about prescriptions and other drugs. Providers should explain that urine drug testing is for ensuring the safety of the patient. After testing, providers should share any unexpected results with the patient toxicologist and use confirmatory testing. Avoid prescribing opioid and benzodiazepines at the same time whenever possible. If an opioid use disorder is suspected, providers should use the opportunity to provide life-saving information and interventions, as well as offer an evidence-based treatment that minimizes opioid withdrawal symptoms as much as possible. In terms of treating patients with opioid use disorder, initiating medication-assisted treatment, or MAT, which combines buprenorphine or methadone with behavioral therapy, has been shown to be effective. Naltrexone is another MAT option for non-pregnant patients with an opioid use disorder. Providers should use the Diagnostic and Statistical Manual of Mental Disorders, DSM-5 criteria for assessing the presence of opioid use disorder. For reference, CDC's guideline defines opioid use disorder as a problematic pattern of opioid use leading to clinically significant impairment or distress manifested by at least 2 defined criteria occurring within a year. Consider prescribing naloxone for patients with opioid use disorder to avoid overdose. In our final group activity and knowledge check, we'll pause for 8 to 10 minutes to go over Appendix C, Pillar 3 knowledge check. We will break into small groups for a brief discussion and then run through a scenario and answer a related question. The material covered in this training brings up a number of frequently asked questions. Dr. Jay Butler is Deputy Director for Infectious Diseases at CDC. In a conversation with Dr. Butler, he discussed the reoccurring questions from providers related to CDC's guideline for prescribing opioids for chronic pain. First question, when and how do you taper? According to Dr. Butler, the 90 mmE dosage can be thought as a threshold of concern. As such, it is an opportunity to consider the difference between dependency and addiction, and that the period of exposure and dose does have some variability. Even if patients exceed this threshold, it is critical to not fire patients or cut them off cold turkey. These patients may be dependent without being addicted. CDC has guidelines online on tapering that were not included in the 2016 guideline. For successful tapering, the provider and patient need to discuss and acknowledge how very difficult it can be when a patient is fearful of pain or withdrawal. Some practitioners have said, "I don't want those patients in my office." Dr. Butler's response, "They're already there. They're just not telling you." He says being a good doctor means taking care of everyone. For effective medical care, it's important to know if someone in recovery, something else that providers rarely explore and patients rarely disclose. Yet, we prescribe opioids to them. Absent those critical conversations, the best outcome is for the patient to toss the meds and suffer whatever the acute pain syndrome was. Worst case, they relapse and maybe overdose because they know what they used to take and are unaware that during recovery, they have lost their opioid tolerance. The follow-up to that question is, aren't you enabling? Dr. Jay Butler says this comes up around many topics, especially harm reduction. Stress that addiction makes people do things they would never normally do, just as Alzheimer's makes people do things they would never normally do. This to frame addiction as a health condition involving the brain, but also acknowledge the differences. Namely, addiction leads to more property crime. Keep in mind whoever is asking this may have been robbed themselves or had their office broken into. I'm sure you might have questions too, and there are several avenues for getting those questions answered. Thank you everyone for your participation in this training on opioid prescribing practices for chronic pain. As a reminder, we cover the 3 key pillars according to CDC's guideline. Number 1, determining when to initiate or continue opioids for chronic pain. Number 2, opioid selection, dosage, duration, follow-up, and discontinuation. And number 3, assessing risk and addressing harms of opioid use. We encourage all participants to go home and complete each of the CDC training modules on opioids. If you have a smartphone, you can also download the CDC guideline for prescribing opioids for chronic pain mobile application to ensure you have this information at your fingertips. At this time, we wrap up our video presentation. The on-site trainer will guide you in the post-assessment before this training ends. There will also be a question and answer period with your trainer.